Welcome to the final section of Basic Arrhythmia and Advanced Arrhythmia. We'll be talking about pacemakers. Thus far through the course, we've talked about native pacemakers, and those are the organic ones. The cells themselves, the heart that you were born with, and those parts that can generate an impulse on their own to create a heartbeat. With this part, this last section, we're going to talk about the artificial pacemaker, or pacemakers, the ones that are implanted by the healthcare industry. So we'll talk about those in various ways. For the basic arrhythmia group, the focuses I have for you guys is going to be the terminology, common rhythms, and by common rhythms, you can almost think of that as common functions of pacemakers, things like being atrial paced, ventricular paced, AV paced. In some cases, patients have demand pacemakers where their underlying rhythm is okay most of the time, but occasionally that pacemaker needs to kick in to help make up the difference. So we'll talk a lot about those, and then there's a few other specialty items I do at least want to touch on, because this is a great place to talk about those and make you aware of some finer points on taking care of pacemaker patients and what to do in case of emergencies. As for the advanced arrhythmia group, it really is just diving deeper into each one of these items. Some extra terminology, the functions, and more importantly, the malfunctions. For both groups, you'll find that reading strips for pacemakers is very easy. You just look at it and you can pretty much tell right away almost, except when it comes to the malfunctioning and when they're not doing the job they're supposed to. At that point, they can get really complicated really quick, and hopefully I'll give you the remaining tools you need to be able to dig through that and figure out what's going on, or at least have a good idea so that when you're communicating with the cardiologist, you can get the job done quickly. And here we go. Beginning with terminology, the inherent pacemaker or native pacemaker is the one you're born with, or any other part of your heart that can generate an impulse. Artificial pacemakers are devices that we implant to artificially stimulate the heart and cause depolarization. And that's the big trick. It's an artificial electrical impulse that causes the depolarization. And as we go forward, you'll see that there's a spike, which is the artificial part, and then the depolarization. So you should see a QRS or something like that. We'll get plenty of practice with that part. The goal of all of this is to maintain an adequate heart rate. And in fact, that's the indication for placing a pacemaker pretty much all the time, almost. It's the idea that once it's been established that the patient has a bradycardia, and that's the big one. Once we know for certain that the patient has a bradycardia or a conduction disorder that warrants permanent pacemaking, the cardiologist will then determine what the most appropriate pacing device and mode is for that patient. And it really is just up to the MD, and it has to be tailored with every case. Other terms that are important to know, when we talk about the generator, that's actually the battery portion, what provides the electricity. The conducting wire is what carries the electricity to the inside of the heart, so an electrode, and then the return wire completes the circuit, because it's just like a light switch. You have to have a wire going in and a wire coming out. The more common types of pacemakers we run into can be divided into two categories. You have the permanent pacemakers, which is what most people think about when you hear one. Grandma or grandpa's got a pacemaker now. These are ones that are actually implanted. It goes underneath the skin, and the wire, as you can see here, actually goes through the subclavian vein, superior vena cava, and actually terminates inside the right ventricle. And that's the most simple and pretty much most common version that we talk about when a person gets a pacemaker. It gets more complicated from there, but we'll just start with this for now. This one here is long-term. For years. In fact, my grandmother got her first one when she was 80. She actually went through 3 generators. She used up that many batteries. She had a pacemaker for over 14 years. So that just kind of indicates what kind of time frame we're looking at when we try and do permanent pacemakers. Now, on the other side, we have our temporary pacemakers, and there's 2 subsets for that. The one that you've probably seen or heard the most about is going to be your transcutaneous. And this is essentially the pads. So all of these lectures prior, when I talk about the bradycardic patients and you put on the pads, that's what I'm talking about. There's actually 2 flat stickers that you put on the front and back of your patient, or however the picture on the sticker says to place it. And that's what conducts electricity. The electricity goes through one electrode and comes out the other and runs it through the heart, causing it to contract. They hurt, by the way, so make sure you medicate, because it's like grabbing a hot fence, for those farm kids who may have done that in the past. So keep that in mind with pads. They hurt when we use that to generate a heart rhythm, a heartbeat. The other version is going to be your transvenous, and this one actually requires central venous access. So it usually goes through a sheath or something like that, and it actually follows that same path that it goes through here and ends in the right ventricle. You'll notice how this long wire then has a box here. There's actually an external wire and an external box that sit next to the patient while this is running. And that's that thing that really points out that it is temporary. Hopefully only a few hours, not more than a day if you're lucky, that we have to use that one. So this one here uses a wire. So temporary pacemaker, transvenous, that uses a wire. Transcutaneous, that uses the pads. And then permanent pacemakers are implanted under the skin and are there for years and years. As a final bit of comparison, I don't want to forget to mention this. The pads, they hurt a bunch, but with the temporary, because that wire is inside the right ventricle, there's no pain associated with it at all. And that's actually something that gives it an advantage. So the transcutaneous is like the true emergency, where you don't have time to do more than just put pads on. The next step to that would be the transvenous, when there's a little bit more time to put it in, but it's still technically emergent. And then finally your permanent, that's more of a planned situation there. Artificial pacemakers deliver an impulse to the heart via which 3 methods, or which 3 types of pacemakers exist? Well, in terms of artificial, we have temporary transcutaneous pads, so that one's correct. We have temporary transvenous wires, that one's correct. Telemetry monitoring wires, well, right there it says monitoring, so that's not accurate. And then of course there's permanent transvenous wires, and that's your classic pacemaker that most people think about. So those are your top items for how we deliver pacemaking to patients. Temporary transvenous wire pacemakers are typically connected to which chamber? And if you go back to the diagram, you can really see what those options are, but it has venous in the title, and so you can kind of check off the left side of the heart because that's more of the arterial side, which then leaves you with right atrium and right ventricle. And if you look at the diagram and how it was explained, that it's not the atrium, it's that ventricle is where most, pretty much all, temporary transvenous wire pacemakers are connected. Pacemaker classification. Like all things, we organize them in a way that we can tell the difference between one type of pacemaker versus another. I'm not going to go in great detail through this, but the idea is a progressive one, where we look at at what chamber is paced, what chamber is sensed, how the pacemaker responds to the sensing. And those are really, really cool things. The short version is that pacemakers nowadays are very smart. In fact, they're smarter than your phone. And way more reliable, by the way. Because let's be honest, if your life is dependent on this pacemaker functioning, you can't have it glitch out or anything like that. Really cool things that a pacemaker can do include the mode switching. And mode switching is really neat because it actually changes its function based on what it sees in terms of your native response. So that let's just say it's set to pace you all the time. But if your natural heart is able to pick up the pace and is working well enough, then it actually kind of shuts itself off so that you don't pace when it's not necessary. And that's a really cool thing. The other neat thing that it does is something called rate responsiveness. And the reason why that's cool is it actually changes the rate based on what the patient's trying to do. Or their activity, based on patient activity. So it makes sense. So if you're doing something that, let's say, walking up the stairs or, I don't know, cleaning the house, whatever, the pacemaker is able to pick up the pace so that you can have an adequate cardiac output to get that job done. And these are really, really neat functions and make a big difference in people's ability to just perform ADLs. The simplest pacemaker that you'll run into is going to be VVI, and that's your temporary most often. And those temporary pacemakers just, they pace the ventricle, they sense the ventricle if something's coming through already, and they inhibit if the patient's native rate is adequate. Your higher end ones, which would be, your D, and in fact D, would be sensing both atria and ventricle, pacing both atria and ventricle, inhibiting accordingly, and additionally, if you've got rate modulation, or even better, or in addition to multi-site pacing, so that it looks at the atria. If the atria paces, it does something. If the atria does something, then it doesn't fire. And same with the ventricles. And so that you could see this kind of be in that Cadillac model where it is able to do everything or do nothing accordingly. Providing some specific examples to help clarify what I've just been talking about. The pacemakers are divided into two major categories: single chamber pacemakers versus dual chamber pacemakers. In the single chamber pacemaker group, they stimulate either the atria or the ventricles, but not both of them. And so the way those would be classified might be something like AAI, where it senses the atria, paces the atria, and inhibits if the patient manages to produce their own native rhythm. Another version of that would be something like VVI, which is those temporary pacemakers, sense the ventricle, pace the ventricle, but inhibit if the patient manages to kick something out. The other side of it would be the dual chamber pacemakers. And in that case, it actually is capable of stimulating both the atria and the ventricles. And this is really, really cool because it allows us to do something called AV synchronous pacing. An example of that would be DDI, and you can go back to the previous slide to look at that classification closer. But the idea is that you maintain cadence between the atria and the ventricles so that the pacemaker is completely in control, and it says, I pace the atria now, and then after an appropriate amount of time, I pace the ventricle to, again, artificially create an appropriate heart rate, heart rhythm, things of that nature. Another higher end version would be the biventricular pacemaker, which would be something like DDVI, where it not only paces and senses the atria, but is also capable of doing the right and left ventricle independently. For the advanced arrhythmia group, we'll go over that in greater detail. To just give you the quick preview of it, it's something called CRT is the type of therapy that is, and that stands for cardiac resynchronization therapy. Advanced arrhythmia, we'll dig into that more. Pacemaker function. Some additional terms that I have mentioned, but not quite explained yet. Capture, sensing and interpretation. Capture is essentially the heart reacting to the pacemaker impulse. And just to kind of let you guys know, going forward with this section, I'll refer to pacemaker as PM just to try and keep it short. But essentially it's this idea that the artificial stimulus from the pacemaker causes the heart to depolarize. So stimulus, depolarization. So what you should see is a spike on the ECG. You'll know what I mean by that when we go forward. Causes a reaction from the heart. So if you see a spike and then nothing happens after it, it means you have no capture. But if you see the spike and then the heart depolarizes accordingly, you know that it's doing its job. That's one part. The second part is going to be sensing. And sensing essentially comes down to the pacemaker, the generator, being able to read the heart and respond appropriately. And so what we're talking about with that is this is the part that really makes the devices super smart, is depending on the settings, if the pacemaker is designed to, it's always looking at the heart, but if the pacemaker is designed to look at the heart, and if it sees that the patient creates a P wave or a QRS, then the pacemaker does not fire. It senses that and says, nope, I don't need to do anything. Whereas if it's looking and it sees, okay, you've not done anything on your own, I'm going to go ahead and create an impulse, so hopefully we get capture, etc. That's what this is all really getting about, and it's that ability to withhold stimulation if that's what it's programmed to do. The final bit is interpretation, and with interpretation, really, ultimately, that's our job, well, the cardiologist, and our job. And we're looking to see the relationship between these spikes and the patient's own complexes. Looking to see that, is it firing when it's not supposed to? Or should it be firing and it's not doing its job? That's really what the interpretation stuff comes down to. And that's why talking about the classifications and things like that becomes important, because if you're going to figure out whether the pacemaker is working correctly, you really have to know what the settings are. That becomes really, really tricky, and pardon me, that's the deeper part. For now, just realize that capture, sense, and interpretation. Let's take a look at a paced rhythm and hopefully make some sense out of what we've been talking about so far. Our rate, and we're going to do this just the way we always have, and of course it is a 6-second strip, 5, 6, 7. We have a rate of essentially 70. It is irregular for sure. there's no pattern to it per se, but we do have paced and native beats. We have, in the cases where there are paced beat, we have one spike per QRS, and there's really no ectopy. In terms of the P waves, we really don't have any. In fact, we have F waves instead. So that's a good sign that we probably have underlying atrial fibrillation. That would be my assumption. Because there's no P wave, we have no PRI. In terms of the QRS, what can we learn? Well, there's two types, so we'll talk about native. And for the native, and so C, D, and E, as well as G actually, are all the native beats. And those are uniform. They have an RS pattern. And if we measure these out, we get right at about 1.5 to 2. We'll round up and we'll say 2 times 0.04 equals 0.08 seconds. So we know that the native beats are normal, or at least have a normal width QRS. As for the paced beats, what can we tell about those? And so the paced beats are the ones with the P in front of them. So it's going to be beat 1, 2, and 6. And we have a spike before wide and tall QRS. In fact, they have a completely different pattern compared to them. They actually have a RS pattern. Sorry, I misspoke. It has a QS pattern where it goes really deep and then comes back up. If we were to measure these out, we would start right about here where the QRS begins, and right here at the J point, which is about here, and that's 1, 2, 3, 4. It's about 4 small boxes. 0.16, which is definitely wide. These are the hallmarks of ventricular pacing. That you've got that sharp spike in front of it, and what I mean by spike, it's this solid black line that you see immediately followed by something happening in the heart. And in this case, it's a wide QRS, so that's how you can tell it's V-paced. If we were going to just go ahead, wrap it up, and call it what it is AFib with demand ventricular pacing. And that is your official name for this one. And this captures that idea that pacemakers aren't really meant to do everything for the heart. It's not meant to supplant the heart as much as supplement. It should be there as an assistant, not the one to take complete control and do everything all the time. So this is a very, very good example of how modern pacemakers function. To add some more context to this, to give you a better idea of what's going on, I'm going to erase some of these marks here real quick. You can figure out exactly, well, not exactly, but very closely to what the pacemaker's function is based on when it kicks in. So if we measure between beat number 2 and beat number 3, which is about right here, and the beginning of the QRS, which is right here, that comes out to about 25. And then you notice across here to the next native beat, this one's right around 19. But then if you look at the start of beat number 5 all the way across to beat number 6, that's about 30. And if you put those numbers together, you can have 1500 divided by 25 gives you 60. 1500 by 19 gives you 79. And then 1500 divided by 30 gives you a rate of 50. So it looks like this patient's pacemaker is set so that if the heart rate drops below 50, which is what happened here, the pacemaker will kick in and help keep the rate above that mark. Whereas in this section here, the heart rate was fast enough that the pacemaker didn't have to do anything because the native rate was adequate enough. The last question you may ask is, why does ventricular pacing cause, I'm going to look at beat number 1 here, such wide QRSs? And the reason for that is that pacemakers, it's just a wire essentially jammed into the side of the heart. And because it's not part of the natural conduction system, it functions not unlike a PVC or something like that, where it's just causing a stimulus and it causes the rest of the ventricle to depolarize. And so that causes the cell-to-cell conduction. And that's why you wind up with such a wide and tall QRS, is because of that cell-to-cell conduction that occurs through there. And you'll even note that you have that inverse T waves, that the QRS goes this direction and the T wave is often opposite of that because of the cell-to-cell conduction. Let's look a little bit closer at single-chambered pacemaking, because this is the simplest version that we have, and you can build upon it accordingly. So in single-chamber pacemaking, the most common by far is going to be your VVI, where it senses the ventricle, it paces the ventricles only, and it is inhibited by native impulses. And what that means is it's looking at from the ventricles So if the patient is able to kick out its own QRS without the assistance of the pacemaker goes, great, awesome, you're doing it on your own, I don't have anything else to do. And that's why we use this one most often, because it allows us to minimize the amount of work that the pacemaker has to do. And this is very common. It's essentially always used in temporary, unless you're in a really high-end institution. And for someone who just needs some assistance from the pacemaker, you're permanent as well. And so that very first graphic I showed you of the different types, VVI is what a very simple permanent pacemaker would look like, or at least the function that it may serve. What are your indications? Why would we even put a pacemaker in a person? Well, dangerous bradycardias is a big one. Your third-degree blocks is a great one. As well as if the person has a really, really slow sinus bradycardia simply because of whatever situation's going on, this is something that we can give to help them out. Or even if they're in a second degree that hasn't gotten absolutely terrible yet, but it's never going to get better, they may earn themselves one for that. The drawbacks of having this type and this setting is that because it only paces the ventricle only, you aren't pairing it with whatever's going on in the atria. And that can cause the AV dysynchrony, which is better looked at as loss of atrial kick. And if you remember, that can decrease your cardiac output by, 20 to 30%. But again, in people who have these dangerous bradycardias, particularly third-degree heart block, it is absolutely better than nothing, because this can be the difference between someone, being alive and not. And that's why this is our introductory level pacemaker that's typically used. We'll mark out, we have a 6-second strip. We can definitely tell that we are regular. No ectopy, no pattern. Spike yields a P wave. And I do want to make mention that the reason why we take the time to say spike equals a P wave and things like that is sometimes you don't really see the P wave. Sometimes you just see a spike, there's a little bit of squiggle, and then a little bit later a normal QRS happens. And that's common with atrial pacing, as you may not always see that P wave big and clear. It's one of the reasons why I picked these strips, is so that you could see that P waves are actually generated by atrial spikes when they do occur. If we measure it out then, since they're nice and regular, we got a distance of 19. That comes out to about 79. As for the P waves, native, well, we don't have any native. They're all paced. And what can we tell from that? Well, they're upright, so that's good to know. And uniform. And that includes both the pacer spike itself is consistent across there, as well as the P wave that it winds up generating. And that we have one spike per P and per QRS, so that we don't have a spike making a P wave and then nothing. These P waves that are generated do yield a QRS, and that's really good to know. The PRI, as we measure it, let's go from here to about here. 1, 2, 3, 4. 0.16, and so that's normal. Then we'll take a look at the QRSs. And we only have native QRSs, right? None of these pacemaker spikes directly cause a QRS depolarization. It's all completely natural. QRS shape. And if we go ahead and measure these out, I guess we started here, and so we'll end here. That's about 2.5, we'll call it. Okay, and so that is normal as well. So ultimately, what am I going to call this? Well, atrial paced with %100% capture. Or you could say 100% atrial paced. Or you can say 1-to-1 atrial pacing, whichever you're more comfortable with. So here's another example of what paced rhythms can look like. We have a ventricular demand pacemaker in this case, and let's prove it. Our rate, just like always, I'll go 1. Of course, this is a 6-second strip. We've got about 7 beats across the screen. It is definitely irregular. it's very close to being regular, but if you did measure it out, it's got some problems because it's narrow through here and a little bit wider there. It has paced and native beats. We have no ectopy. And in the cases where the patient is being paced, we have 1 spike per QRS, which is an important thing to note. Going forward, what do we got for the P waves? Well, from a native standpoint, we have no P waves at all that we can really see. In fact, it's closer to F waves, in which case we can probably assume that this patient's got AFib as their underlying rhythm. We have, from a paced standpoint, we have no pacemaker spikes that cause a P wave. So we don't have anything there. PRI. The QRS, native. And so our native beats are actually, I'll put an N next to these, are 1, 2, and 3. And those are uniform. They have the RS pattern. And our width, if we measure that out, we'll just go with this third beat here, is somewhere between here and here. I don't like that as much, so I'm going to go down here. We've got 1, 2, 3-ish. So we'll go 3 times 0.04 equals 0.12. So it's right on the edge of being normal. In terms of our paced beats, if we just look at them without even doing any measurements, we can tell that they're uniform, they're wide, and they're tall. The native beats are tall as well, but the bigger trick is the fact that they look particularly wide. So if we even measure one out, we would get, we'll do beat number 6 because this is kind of out in the middle of nowhere. Got 1, 2, 3, 4. 4 small boxes. So they're wide, they're tall. 4 times 0.04 equals 0.16, which is not normal. In fact, it's wide like we'd mentioned. And we can also note that the spike, which is right here, just like the arrows point to, a spike yields a QRS. And that's the hallmark of being V-paced. So we take in the fact that it is irregular, it's got a normal rate, and that we've got F waves. This is going to be AFib with demand V pacing. Just like that. Again, like we'd mentioned in the previous slide, it's cell-to-cell conduction that causes these wide QRSs to happen in these situations. Other things I'll point out is if you measure these out from the start of your QRS to the start of your QRS between 2 and 3, that's 22 small boxes. And that gives us a rate of about 68, which is a nice good rate. And then if you measure from here to when the stimulus occurs, well, not here, sorry. You've got a rate of, about 26. And that comes out to about 58. And then if you measure between these here, you get 25. And what this tells us is that the pacemaker is set so that if the patient's heart rate drops below 60, it'll kick in and help keep that rate at that speed if necessary. And that's the whole point of the pacemaker. So we just went over what a single chamber pacemaker looks like. A dual chamber pacemaker can have a lot of different combinations, but the highest end would be something that is a DDDR, where it is sensing the atria and the ventricles. So that's where it's looking. And it paces the atria or ventricles, or both, and that's where the action is. It can be inhibited by either, and that gets a little complicated. I'll come to that in a second. And I added the R on here because then that just puts a little bit of rate responsiveness on there too, which is just another feature that can be on there. This winds up being your Bentley, your Rolls-Royce kind of pacemaker. If you want to, you can think of it as the latest version of your iPhone, Samsung, whatever, with the latest watch included. It has everything you could possibly hope for. All the bells and whistles. Indications for something like this is that you've got a broken sinus node and a broken AV node, so it requires that kind of assistance, or you've got sinus node dysfunction. But a normal AV node. There's different situations. And again, that comes down to the cardiologist determining what's most appropriate for that patient at that time. What this comes down for us when we're doing interpretation is realizing that this patient can have any one of these combinations on a single strip. They could be in a normal sinus rhythm, potentially. They could have atrial pacing, but a native QRS. They could have AV sequential pacing, where you're pacing both the atria and the ventricle. Or that you could have atrial sensing, and you've got a normal P wave, but then it kicks in and it causes V pacing. And that's what makes these so cool, is that it can do almost everything you could possibly want it to do. So what does a dual chamber pacemaker look like? And so this will be an example of a DDI, where the patient has dual sensing, dual pacing, and will inhibit if it senses something appropriate. And we'll just work it out like we always do. And we're going to mark these. And so this one is really, really good because you can see those spikes clear as day. And so we've got a rate of about 70. Of course, that was 7 times 10. We are very regular. And that makes sense because pretty much every single beat is paced. We have 2 spikes per beat, and so we need to look at that a little closer. And we don't have any ectopic. And there's no real pattern because it's nice and regular. In terms of a P wave, the native, we actually have none. Paced, we have really nice ones actually, right here and here. It's the same throughout the strip so that they are upright and uniform. And I will say that in real life you may not actually always see a clear P wave. It may just be a tiny little change. It may not be very, very clear to see. But the spike being there is an indication that they are atrial paced. And that this paced one follows spike. And that we have a 1P per QRS. And in fact, that's 1 spike per QRS. The PRI, if we're going to measure it, we'll measure from the start here to about right about here. And so that gives us 1, 2, 3, 4. which is normal. And you'd expect something normal when the machine is in charge of determining how much time to give it before the QRS begins. And yes, I didn't mark from exactly when the spike began so much as right after the spike, and when I actually see the depolarization occurring from the patient. So we'll talk about the QRS. Your native beat is non-existent. Your paced beat is uniform. It follows the spike every time. So we have a 1-to-1 there. They are wide and tall. And if we go ahead and measure those out, and we'll just go ahead and use the same one. 1, 2, 3.5 or so. Which again falls under that wide. It's 0.14. And so that gives us everything we need to say that this patient is V-paced. And so you've got a spike causing a P wave, and then you've got a spike causing a QRS. That is something that we would call 100% AV paced. Or you could say something like AV paced with 100% capture. I've also seen it as 1-to-1 AV paced, and I've recommended that in the past because it's just simpler to write. Any of these are really appropriate as long as you're pointing out the fact that the patient is totally dependent on the pacemaker during the strip that you see in front of you. So now that I've introduced you to the terminology regarding pacemakers, how do you evaluate someone's pacemaking to see if it's working the way it's supposed to? And so here's the steps. It's not unlike what we've done prior with going through any of our strips. It just has a few different things that you need to focus on. First off, you're going to identify the pacemaker spikes, and sometimes they're very small. In fact, you may not even see them on the ECG strip, and we rely on our monitors to help give us an indication if that thing's happening. Of course, you can always check your patient, because they should have a pacemaker implanted in their chest. If that's there, then obviously we have to dig in and figure out if their pacemaker is functioning or not. So once you've identified spikes, the next thing you need to do is look at the relationship between the spikes and the patient's complexes, the depolarization. And what that does, a more simple way to put it is, does the spike make a complex? Or is the spike just standing alone, floating on its own? And then what's the shape? Did the spike happen and it made a very telltale response from the heart that a pacemaker should, or did the spike happen but then the beat looks perfectly normal? Things like that are what you want to be aware of. Next thing is the pacemaker doing what it's supposed to do? You need to know what the classification is if you're going to dig into that. Often I strongly recommend checking the EMR, or the patient's supposed to have a card that states what brand their pacemaker is and things of that nature to try and learn what's going on from that regard. Contacting the representative The Pacemaker Rep is a great place to start too, because if you know what brand it is, then you can call them and they can look up that stuff on their records. That's a few extra steps. While you're looking at your strip, though, you can ask the question, is the rate reasonable? We want to see normal speeds. Somewhere from 60 to 80 beats per minute. If it's up over 100, or up to 100, that's not the worst thing in the world, but ideally we'd like it to be as close to normal as possible. Are the spikes competing or falling near T waves? So if the spike is competing, it's actually happening on or within the QRS, or competing with the T waves. And so again, it's happening during that absolute refractory period. The last thing you want to ask is probably something that pops first in your head, which is going to be, is the pacemaker functioning consistently and reliably? Is it not doing anything at all? Or is it sometimes working and sometimes not? Those kinds of things will come out. But by the time you get to step 6, you should already have that answer. Other things you could maybe encounter is problems like a runaway pacemaker, or if it's got a defibrillator, it's shocking. But those are other things that we'll go through as we move forward. This is a simple looking slide, but it's got a lot of big ideas on it. I want to just briefly go over a lot of the common pacemaker malfunctions to make you aware of what can go on. The first one that we'll just talk about is going to be loss of capture, and it is essentially that the spike is not making a QRS or P. Either a P wave or QRS. The other problem, the next problem that could occur, is a failure to sense. And with failure to sense, you've got a spike at the wrong time. There are 2 subsets of that that we can identify, and that's more for the advanced arrhythmia group, so I'm going to hold off on those. But if you take that next section, you'll learn more about them at that time. Another thing that can happen is what's known as a runaway pacemaker, and essentially you've got too much, and the patient is tachycardic while being paced. And that can get really complicated really quick. I just want you to make you aware that runaway pacemaker is a thing that can happen. Lastly, there's just battery failure. That can happen. It can wear out. Again, it's just like your phones. The more you use it, the less battery life it has. Typically, nowadays, these can last 6 to 8 years. And even if it is beginning to failure, patients with pacemakers do frequent check-ins, at least once a month. And with that, when a pacemaker is getting close, it actually has a thing built in that it gives you a 3-month warning. When it's starting to get low, it actually, during those communication periods, lets them know that the battery is beginning to get low. Okay, beginning as always. And you can already see that beat number 6 does not look like the others. And so because I don't really actually have a QRS with beat number 6, I'm going to have to say that my rate is 7 times 10, and that equals 70. We can say that the response rate, that the paced rate is closer to 80, but we won't dig into that right now. Regularity, we're definitely irregular. We have a missed beat at number 6, or I should say a pace or spike that does not cause a beat, if you want to think of it that way. We don't have any ectopy. But for the rest of them, other than number 6, we have spike causing QRS. So in terms of a native P wave, I've got basically F waves. Not a whole lot, but you can kind of see them through here between beat 4 and 5. I do not have a PRI because I have no P waves. In terms of pacing for the P waves, I don't have any, so there's nothing to do there. QRS, native, I have none. Paced, what do I have? Well, they are definitely uniform. You could say that they are QS in shape. They are wide and tall. If I go ahead and measure them out, we'll just use beat number 4. Starts about right there. 1, 2, 3, 4, 5. So yeah, definitely wide. In terms of the tall, of course, I'm going to use my gauge here. And we can tell that it exceeds that mark, so that tells me that we have a higher amplitude. Number 6 is missing the QRS. And what this really comes down to then is, without doing much else, we can say that we are V-paced with loss of capture. That's about all we can say about this. You could maybe say that they're 100% V-paced. In fact, you could even add on a fib with 100% V-paced with some loss of capture if you wanted to do the absolute maximum. In this case, it wouldn't be inappropriate to just say V-paced with loss of capture because that really does sum up what's going on. But you went to the effort to say those look like F waves. I'm going to go ahead and make mention of that. Ultimately, to take care of this patient, or I guess I'll say this, causes are going to be that, what we talked about before, which is lead fracture. If you have inflammation is another good one. So if you think about it, you just jammed a wire into the side of the heart. That may be one of the reasons why it's not functioning properly. Or you could just have injury is another good one. Or dislodge. So if the patient moves too soon after implantation, they might dislodge it. Injury, that would be like a crush injury, like a car accident. Those can make these kinds of things happen as well. This is never a good thing, and it really warrants investigation by the cardiologist, so we need to interrogate as soon as we can. Thankfully, the patient still has a heart rate of 70. It's not happening all the time or extremely frequently based on this strip, but you still need to keep in mind that that's not what it's supposed to do, and we need to try and figure out what's going on. We just got done talking about loss of capture, so let's take a look at what failure to sense looks like. Just by, as I number these out, looking at it, you can tell that it's definitely irregular. We have some paced beats, some that are not, but the timing is all over the place. And we're going to go ahead and pull this apart and try and figure out exactly what's going on. So 7 times 10 gives us 70. Very irregular. We don't have any ectopy, there's no pattern, but what we do have for sure is that we have pacing at the wrong time. In terms of the P waves, from a native standpoint, we don't have any P waves. All we really have are F waves. And so we can probably assume that this patient has an underlying AFib based on the irregularity of the natural beats. From a paced standpoint, we don't have any paced beats or any pacing that results in a P wave. So we can tell that we're not dealing with something like that. Because there are no P waves, we have no PRI. In terms of the QRS, so which ones are the native beats? Well, that's actually 1, 2, 4, 5, and 8. Those are all of the native beats. And we can tell that those are uniform. They have a QS pattern to them. In terms of width, we'll just go ahead and measure beat number 2. It's about 2.5. 0.10. So we have a normal width QRS for our native beats. Our paced beats, those are going to be numbers 3, 6. Those are the only ones we have. So number 3 and number 6. Those are wide and definitely taller than the non-paced beats. So right away we're assuming that this one's going to be V-paced. If we want to measure it out just to confirm that those are the widths, of course we can measure from about right here to about, I would say this is probably our mark. So we've got 1, 2, 3.5. Sorry, I'll get this written here. 5. So that is again wide. So that's helping confirm that we've got V pacing. The part that gets interesting is the spikes themselves. And so I'm just going to go ahead and, if you look at the ones that are marked as P's, you can tell that the spikes that are associated with beat number 1, number 4, and number 7 are happening at the wrong time. In fact, that they are late. And when they occur, they're not causing capture. And that's because they're occurring at a time when the heart, the QRS, is not capable of responding to it. And that's a key sign of loss of capture. But the loss of capture is due to the fact that they're happening at the wrong time. And what this comes down to is, I'll just kind of read some of my notes here to try and make sense out of it. The underlying rate is atrial fibrillation, and we've got V pacing. The pacing rate is set to about 45, and we can prove that by marking out this one here. We'll measure over, and we mark here, and that's about 33 small boxes. And that comes out to about 45. To help confirm it, I measure the next spike that I can see, and that is also right at around 33. And if I measure it out again to the next spike, I realize that one's off a little bit, it comes out to about 33 again. So we have a pacemaker set to 45 beats per minute. But why is the heart rate 70 and not 45? Well, what's happening is that pacemaker is firing at a very consistent rate throughout, yet the patient's native beats are popping through. So we can assume or deduct that the pacemaker is failing to sense those natural beats that are occurring on their own and then doing its own thing. Ultimately, what I would wind up naming this would be AFib with demand, ventricular pacing, and failure to sense. I realize it's a pretty long title, but again, we've got a problem, so we have to use very specific words to try and explain what we see. As a reminder of things that can cause a failure to sense, they're very similar to ones that cause loss of capture. It's going to be things like dislodgement. So the wire comes away from the cardiac muscle for some reason. Inflammation's another good one. And yes, again, I apologize for my poor spelling and handwriting. And just failure of the programming itself. Maybe it's just not dialed into the right way to be able to tell what's going on and respond appropriately. Continuing on, runaway pacemakers, another malfunction that can occur. Thankfully, because their pacemakers are smart devices, this happens less often than it used to, but it's still something that does come through hospitals every now and again, or clinics for that matter. Runaway pacemaker. The idea, this is a short strip. It's not a full 6 seconds, but it's nice and regular, so the event is what we're looking at more than anything. If I measured these out, we'll say from here, the start of the pacemaker spike, to the next one, you get right at 13. And that gives you a rate of 115. Not terribly tachycardic, but it is. Runaway pacemakers, they can run rates up in the 140s, 150s. They can be very, very high. And so it's important to keep in mind that there's a lot of different factors going here, but for this case, it's tachycardic, and let's dig through it. The regularity, definitely regular. We have no ectopics, and we have no pattern. It's perfectly regular. As for P waves, native, all I could say is likely have F waves, maybe artifact. Very difficult to tell on this strip, but we could assume that that might be something. In terms of P waves that are paced, we don't have any. We only have a single pacemaker spike creating each QRS. There's no indication that there's another spike causing P waves. So we can call that nothing for the PRI. As for the QRS, now they're all paced beats, so we don't have anything native. As for our paced beats, they're wide QRSs, they're tall and tall. If I measure these out, 1, 2, right at 3 or so. So technically that is normal, but we do have the pacer spike right in front of it. Each spike causes a QRS. So even though it is not extremely wide, the ones that are like, 0.20 or anything like that, we can definitively say that those pacer spikes are causing the QRS so that we are V-paced. Not to mention, you'll notice that the T wave is going the opposite direction of the QRS. That's just one more feature that we can use. Ultimately, what does this come down to? Why are they tachy? I've spoken with some cardiologists and what their thoughts and feelings are on this, and at the end of the day, you need to treat the patient, treat their symptoms. So treat patient symptoms. That's what really matters. If this fast heart rate is causing them to feel weak or fatigued, they've got a drop in cardiac output, things like that. So we got low BP, decreased LOC, fatigue, and they may feel like they have a racing heart or palpitations, anything along that nature. Those are the ones where you're going to treat the symptoms and then figure out if the pacemaker's involved or if that's part of the problem or not. Those are your big goals there. Ultimately, interrogation is how you're going to figure out exactly what's going on, and that needs to be read by the cardiologist or someone else that has that level of training. That's Runaway pacemakers. In short, it's all about treating the symptoms of the patient and what they have going on, that kind of stuff. Loss of capture results in which of the following? The pacemaker stimulus does not produce a spike on the ECG. That's not accurate because we know that you can still see the spike when the pacemaker is functioning. The pacemaker stimulus produces a spike, but no depolarization. That's accurate. Loss of capture only counts if it occurs during the absolute refractory period. No, that's not true, so we can check that one off. Rhythms like loss of capture results in rhythms like VTAC or VFib. That's a pretty broad statement and really not terribly accurate at all when it comes to talking about loss of capture. So B is the correct answer. The pacemaker stimulus produces a spike, but no depolarization. So we've talked about loss of capture, failure to sense, runaway pacemaker. What are you really supposed to do, though, if your patient winds up presenting with these problems or developing them while they're under your care? Well, ultimately, it's, care for the patient first. Focus on the symptoms as best as possible and try and treat those. If they've got low cardiac output, so they've got that low blood pressure, they feel the palpitations, the anxiety, try and do the little things you can to try and get them through it. If you know that there's been a rhythm change, the underlying rhythm, that may be part of the problem. If their rhythm changed to something new, that could have been the cause for why we're having these new malfunctions. Ultimately, when a pacemaker does malfunction, treatment is directed at the patient and the underlying rhythm. If you think about it, pacemakers are the treatment. They wouldn't have a pacemaker in place if they didn't already have something pre-existing wrong. So if they've got a severe bradycardia, we gave them a pacemaker as the treatment. Now, if they have a new problem, we need to do whatever we can for that scenario and not make, it's a pacemaker is broke, let's fix that first. So try and keep that in mind, focus on the patient, take care of them, and then as you go forward in that patient's care, then they'll be able to dig in and figure out if the pacemaker needs any kind of adjustments. So as you're at the bedside caring for the patient, try and notify as quickly as possible or immediately, if it's truly an emergency, the cardiologist or an ER provider, either one, depending on what your scenario is, to come and evaluate this patient and see what they can do to try and figure out what's going on. These are the ones that will decide if the pacemaker is responsible. And that's up to them. That's not, the bedside care provider's job, the nurse or whoever. It's up to those guys because that's where their training lies. That's part of their job. Another great source of information and someone you may want to contact at the same time or at the behest of whoever the physician is caring for the patient is the pacemaker reps. They are a great source of information. Even if you just have questions, I've always had great experiences contacting them about patients and their pacemaker function. The patient should have a card on them. And that card's going to say what brand it is. And it may even say what function that the card has been placed under. Or, sorry, the card should say at least what brand of pacemaker the patient has and potentially the functions that were set up on it so that you can have a better idea of what's going on. If you don't have access to the card or if the patient's just presented unconscious and you're just trying to do what you can, check out the EMR. That's an excellent source. Or an excellent record of the device, especially if it was placed in your facility. In those cases, the cath labs and places that do this will put in all the information you need to figure out what type of device it is and who to contact in order to expedite things. Ultimately, you're going to anticipate doing the following. Plan on doing an interrogation. And that's going to need to be done by a trained expert. So either the pacemaker rep themselves or another care provider who's been shown what they need to do in order to use the interrogation device to figure out what's going on. That could be cardiologists, whoever. Adjustment, that will definitely be done by the cardiologist. They're the ones who are going to be able to figure out be able to read it and see what settings are best to help correct the problem. I've seen this done at the bedside a handful of times myself, that they'll have the device open, the patient's laying there, they'll hit a couple buttons, see what changes, make the adjustments, and then we'll write it out, see if that's effective or not, and maybe potentially change it again. It just really is a patient-by-patient scenario. Last but not least, and of course the least ideal scenario, is replacement if needed. If you run into one of those big problems where it's truly broken, either the generator or maybe a lead came loose, things of that nature that require a procedure, don't be surprised if something like that happens. But again, last result, hopefully it never comes to that. I now want to talk about ICD, Implanted Cardioverter-Defibrillator. Most of you've probably heard about this or may be familiar with it, but I want to clarify some things. So the first off, I want to say automatic. And so if you put that in front of there, you have AICD. And essentially the idea is that it's not a pacemaker. It has one job and one job only, and that is to actually defibrillate your patient. It shocks them. Just like in a code blue. You put the pads on them and you zap them, right, to try and get them into a better rhythm. This does that, except it's implanted and automatic. It actually is reading the heart constantly, and then if it senses the appropriate parameters, goes, all right, let's get to it, and zaps them. So AICD, some people, in fact myself even, call it implanted cardiac defibrillator. That's probably a misnomer, but it's just one of those things that people tend to say. But AICD, what the heck is it? Why do we do it? Well, I explained what it is. It shocks patient. It defibrillates them into a better rhythm. Why do they get them? Well, there's two reasons. There's either secondary prevention or primary prevention. Secondary makes the most sense because it is secondary prevention of SCD, which is sudden cardiac death. And let's be honest, we want a machine that'll help prevent us from suddenly dying. The heart itself. What buys people one of these? What did they have to have in order to qualify? Well, they had to have prior had episodes of VTAC or VFib. One of the common scenarios for that would be post sudden cardiac arrest, and that they coded, and we brought them back. So they had VFib or VTAC. We were able to resuscitate them. They've been resuscitated, and now to prevent that from happening again, we put this on. So that's the one big group. The other group is going to be as a primary prevention. And the primary prevention group is, again, of sudden cardiac death. These are the folks that are at an increased risk of VTAC and VFib. So they have a existing cardiac condition that makes them highly likely to need this kind of treatment in the future. A really common example is going to be heart failure patients, where they've got just poor heart function that is highly likely to lead to this. So in either case, it's VTAC and VFib, either the risk of it or the fact that they've had it before, which proves that they need it. That's how they wind up qualifying. The the most important thing I want to share, and I giggle when I say this because I've had it happen, it hurts. The patients, they can feel it. In fact, I've had cases where a patient, it was malfunctioning and it was firing. Well, I shouldn't say it was malfunctioning. The patient kept going into VTAC because their medications, they weren't taking their meds like they should. And so it fired a handful of times in a single day. And it's like grabbing a hot fence. And so this patient would sit there and he would say, "Oh, I feel it coming. I feel it coming." The alarms would go off at the bedside, and all of a sudden, zap, and he would shout so loud you could hear it down the hallway. Like I had other nurses coming in the room going, "What the heck's going on in here?" And it was his defibrillator. Of course, we were waiting for the cardiologist was on their way, and we were making adjustments to try and prevent that from happening. But they could feel it coming. They could feel it when it hit. It is not a fun thing to happen. And so the most important advice I can give you for patients who have an AICD that is going to be firing and that there's a chance of it, do not hold their hand, because you'll get shocked too. In fact, I had a patient who wound up coding, and we were doing compressions, and it was me and another nurse in there because it had just started happening. He actually went down right in front of me, and I'm doing compressions, and she's there. We just got done boosting him. I'm pushing, and sure enough, I got zapped while I was doing the compressions on him. I kid you not. It didn't hurt. It was, for me at least, but it shows you that electricity can be conducted throughout the whole body, even though it's a relatively small amount. So those are things to keep in mind with these patients. Ultimately, what does the AICD do, aside from the really fun story I just told you? AICDs have the capability of monitoring. So some patients just have one of those in, and that's all, no pacemaker. And it collects information about the heart. It just records things. It has the ability sometimes to do anti-tachycardia pacing. So if it looks like the patient's going into a really fast rate, it may send out signals to try and correct that. Of course, cardioversion and defibrillation, that's what it's there for. Bradycardia pacing. Now, in this scenario and this scenario, it is entirely possible for a patient to have a pacemaker and AICD. And that's a very, very common thing and an important question to ask, hey, do you just have a pacemaker, or is it capable of, delivering a shock? Sometimes patients know, sometimes they don't. But if you're looking at the records and can figure that out, that's very helpful. And the combination of the two is absolutely excellent for these types of patients who have very poor heart function. Last but not least, and this is for the advanced arrhythmia group, is the cardiac resynchronization therapy. That is a high-end pacemaker that also has the AICD mixed in with it, so that it can deliver the pinnacle of what we're capable of doing for patients with very poor heart function. As you can tell after hearing me talk about it on the previous slide, I get pretty excited about these because they are very neat. And so here is what it looks like when a patient has their internal cardioverter-defibrillator activated. We'll just go through this like we always have. Ultimately, the rate is going to be difficult to tell because we have two very distinct rhythms, technically three, and let's try and pull those apart as best we can. At the very start, we have a nice fast rhythm, and so I'll mark from here to here, and that's 1, 2, 3, 4, 5, 6 or so. That's about 250. And then here at the end, we're going to measure some. And before I do that, let's talk about regularity. We're irregular. It goes from a tachycardic pattern to not, and there's a defibrillation in the end. So I will tell you right now that this beat here, actually I'll draw them here, that this beat and this beat are both ectopic. They're probably ventricular contractions of some sort. And I'll just leave it at that, and we can kind of go a bit further in a bit. In terms of the truly paced beats that we have at the end, and so there is pacing. We have this paced beat right here, and this paced beat right here. Now you can't see much in lead 2, but if you look at V2, it does give you some better hints that it starts right about here and ends somewhere over here. This one here, that's an artifact pacer spike, don't pay attention to it, but ultimately we've got a rate from this one all the way to this one of 18. Or I should say it has 18 small boxes, which comes out to a rate of about 83, which is perfectly normal. P waves, native wise, we don't have any. And paced, we don't have any either. There's just none to be seen. Without the P waves, we have no PRI. And so now we'll dig into the QRS. At the very start, the native is got an RS pattern and it's wide and fast. If you were trying to figure out what it, or sorry, I apologize, it has has a small R, big S pattern. And in terms of measuring the width, I'm actually going to use down below as my markers for that. I'm going to mark from here to about right here. And so that gives me 1, 2, 3, 4 or so. So we're wide, we're tall, and we're fast. So that's all the information I need to tell that this is VTAC that we have going on at the very start of things. So we'll say native VTAC. So that's the first half, the start of it. In the middle, we really don't have much of anything. What I can tell you is this right here, this whole mess, that is your defibrillation. The device let loose a very large electrical charge designed to completely depolarize the entirety of the heart, and that's why you see so much energy here, is that it just goes off the charts. The whole heart is shocked at once. It resets everything, which is why you kind of have this line here where that whole heart is just kind of recovering from all of that. And then you get these native beats here. And the native beats aren't enough, and so that then you have the pacer kick in afterwards. So QRS wise, we'll just do the end and see what we got. And so we have these ectopic beats. The reason why I know this one here on the far right is ectopic, because this one here looks almost identical, and because, you know, this has no spike. And so the end, with what I have there, it looks like I've got a spike followed by a large QRS. And that is enough information to say that we are V-paced. And so native V-tach goes into fibrillation, and then we go into V-paced. And that's the most I can, the most I can tell from this slide, simply by the fact that that's what information's in front of me. It'll be nice to have subsequent strips after that to give me a better idea of what else is going on. If your other important things just to remind you of, this hurts. So if your patient is conscious, they'll know it. When it goes off, they may present to the ER because it's gone off a couple times that day. Other situations, it may go off during routine care of a patient for whatever reason. Interrogation is going to be huge because you can actually run a report of how often it's happened. And in fact, that ICD records what happened before the shock occurred, which is going to help the cardiologist decide if any adjustments need to be made. Magnets and pacemakers. This is something that I wish had been explained a lot better to me when I had first started my nursing career, and so that's why we're really going to take the extra minute to go over this. Magnets are really important for a lot of different reasons, particularly when it comes to pacemaker patients. Essentially what happens is, just like you see here in the picture, you place the magnet directly over the patient's pacemaker. Or over their ICD. And this is the reason why I'm talking about this right now. When you apply the magnet, it does two different things. If the patient has an ICD, it shuts it off completely. So if you have a patient where the ICD is firing, whether appropriate or otherwise, placing the magnet there turns that off, and the patient will no longer receive those defibrillating shocks, the ones that really hurt. If it's going off a whole bunch and it's not supposed to, you do that to help protect the patient. If it's going off because maybe it's an end of life case, that's a great reason to shut it off, because, well, if it's end of life and they're on hospice or something, you don't want them to be shocked if it's unnecessary, because that's not the kind of treatment you want to provide. So those are two important scenarios I want you to kind of keep in mind. But so that's for the ICD. The other thing it does for the pacemaker is it induces asynchronous function in pacemaker. What does asynchronous function mean? Well, I'm going to write that out real quick in green. Asynchronous function is where the sensing is turned off, sensing's turned off, and it paces continuously no matter what. Basically what happens is the pacemaker now no longer looks to see what the patient is doing, and just goes ahead and paces all the time no matter what. And that's really cool, because if a patient has a pacemaker malfunction where it's firing a whole bunch, like trying to pace the patient really fast, put the magnet on, it slows it down. So now we put these two together. If the patient has a pacemaker and an ICD, it will turn off the ICD but does not shut off the pacemaker. It absolutely doesn't. And I bring this up because I've encountered this scenario before where a patient goes comfort cares. We place the magnet on there to shut off the shocking, the defibrillation feature. And the family assumed that, oh, we're shutting off the pacemaker altogether, and so then the patient their heart should stop and they should pass away soon. That is absolutely not the case. The pacemaker keeps running, and you need to explain that to patients and their families, or I should say, explain it to the family that we cannot turn off the pacemaker using this device. In fact, it brings up some technical and legal sticky situations. And so 3 common scenarios. This isn't all of them, but I just want you to have this thought exercise with me. Is ICD shocks near end of life. That's one. The other one would be pacemaker dependent patients. So you've got a pacemaker, and I talked about the shocks near end of life where, you don't want to be zapping someone when it's unnecessary. Pacemaker dependent patients, someone who their heart would not beat if it were not for the pacemaker. If you shut that off, what did you just do? You turned off their heart. You essentially killed them, for lack of a better phrase. It's like the physician-assisted suicide, that kind of stuff. And that gets really sticky from a legal situation. So we really do just shy away from it altogether. And if the patient has a pacemaker, they're dependent on it. From a hospice standpoint, we keep it running because having a beating heart is kind of looked at as maintaining quality of life. And that person likely has a comorbidity that will be responsible for their demise, ultimately. And the other one is for comfort cares. And in a comfort care scenario, this one we really, really do look at the comorbidities as being a big player here. So let me just read from my notes to make sure I sum this up right. In the comfort care scenario, oftentimes the patient's comorbidities are what has led to the situation where we had to withdraw care. And so an example would be a patient with respiratory failure. And the failure of the lungs will lead to low oxygen in the body and other related problems. That will ultimately cause the patient's demise, and the pacemaker's function will not alter the outcome. And so in those scenarios, we put the magnet on there to keep the ICD from shocking, but then we just leave the pacemaker running because other stuff will ultimately cause them to pass away. In the pacemaker dependent section, you look at hospice scenarios that unless the patient or family has a very, very, very strong desire to discontinue the pacemaker, it's left on for quality of life. And think about it this way. If a patient has bradycardia and they get dizzy and they don't have energy and they look crummy, leaving the pacemaker on there gives them more energy, makes them feel better. And so that's why we'd leave the pacer on. But we'd turn off the ICD because we don't want, they're on hospice. The goal is not to provide a life-saving intervention like defibrillation. And again, back around to the ICD shocks near end of life. They have a profound negative impact on that quality of life, not only for the patient, but for the family that's standing there watching. if you see one of these go off, the whole body shakes, it jerks. If there's any kind of consciousness left in the patient, they shout out. They're in obvious pain. And so turning that off not only helps the patient, but it also helps the family know that their loved one is passing away more peacefully. And that's a good reason to, or one of the many reasons that we do that. Last little bit, just to clarify this while we're on it. Withholding therapy versus withdrawing. Sorry, I got those little bits in there. Sorry. All right, so withholding therapy is the idea that we're not providing something. So that not providing a therapy that may be indicated. So the patient should have this, but we're just not going to give it to them. That's withholding. Withdrawing therapy is where we refer to removal of previous treatment. And, so that we had the ICD and we withdraw that therapy because we don't need to be using that anymore with that patient. And again, as opposed to withholding therapy where it's like that, well, this patient really needs X, but we're not going to provide it. So keep in mind, turning off the ICD in these end-of-life scenarios, that's a withdraw of therapy in order to improve either quality of life or in situations where we don't want to affect the outcome. Placing the donut-shaped magnet over a pacemaker and or ICD causes what to happen? So what does the magnet do? Well, does the magnet turn off the ICD? Absolutely. Does it turn off the pacemaker completely? Absolutely not. It doesn't do that in any way, shape, or form. Does it switch the pacemaker to an asynchronous pacing function? Yes, it does. Do we only use the magnet for interrogation of pacemakers? That's not true. We actually use it for a multitude of things. So that's an inaccurate statement, which then just leaves us with the answer A and C. This strip's a little bit harder to read, so I have it over two different slides. I have this one here so you can read it clearly. The question is, a patient has a newly placed pacemaker. Earlier in the shift, they have rhythm A. Later on, the alarms sound and you see rhythm B. Which action is most appropriate? And so just to look at these two strips and figure out what's going on, it appears that they're V-paced here and that everything's looking fine. You've got a spike for every QRS. Then later on, you have spikes, but the patient really doesn't have anything in the way of QRSs going on. And then you can see here where they get captured again. And so you have to ask, how emergent is this? So we'll go to the next slide. And so newly placed pacemaker, rhythm A, rhythm B, and we have loss of capture. And it's not just one beat, it's a series of beats. And so how emergent is it? Well, would I say no interventions required? Absolutely not. Is this something that the CNA can address? Absolutely not. Is this non-emergent and you can just kind of let the nurse know? Nope, that's not the case either. This is actually an emergent situation. And so you have to decide, is this worth calling an RRT for and having the ICU nurses evaluate immediately? Or do you just contact that primary nurse immediately, but be ready to escalate as soon as possible? Because the patient regained capture here, we just kind of had this run of not much going on. So it's not quite to the point where we're at an RRT yet, but if it keeps happening, that may be the case. So I'm going to go ahead and say that it's emergent. Get a hold of that primary nurse immediately. Escalate if you're unable to get a hold of them. And that's that. Welcome to the end of the basic arrhythmia lecture. I again want to thank the telemetry techs and nurses. I want to thank the telemetry techs and nurses throughout the years who have saved strips for me, that have, thrown them on my desk, have asked really great questions to try and help all of us get better at doing this. I couldn't have made this presentation without them. And it's that never-ending curiosity that really drives all of this. So thank you from the bottom of my heart. And of course, thank you, yes, you, the person who is sitting in front of some kind of monitor right now watching this. You've made it through it. It's a ton of information. I completely realize it. That's why it's on a video, is so you can go back and rewatch it and, try and make more sense out of it. I'm going to stop now and let you get to the final test, because there's a whole lot of strips you're going to have to start digging through. Good luck.